Thank you, Chairman. Good morning, ladies and gentlemen. I will talk about which imaging studies are needed in the diagnosis of CTEPH. Actually, I'm Korean, and if I talk with this topic with Korean, I will perform more better. But I have nothing to disclose. This is on all the diagnostic criteria of CTEPH, including the symptom related in the pulmonary hypertension and the hemodynamic criteria, mean pulmonary artery pressure more than 25 millimeter of mercury, and the pulmonary artery wedge pressure less than 15 millimeter of mercury, with the imaging findings with the chronic organized thrombi and embolism in the elastic pulmonary arteries, and effective the anticoagulation more than 3 months. You can see the acute thrombus in the vessels in acute pulmonary thromboembolism. As time goes by, thrombi can be changed into chronic organized thrombi with laminated crescent shaped irregular contour, and refractory stenosis, recanalization, web band, and slit, and the total occlusion with the Pucci defect. This is, if you find these features in the imaging studies, you should consider the presence of CTEPH and CTEPD. Although the CTEPD and the CTEPH have the similar features in the imaging studies, CTEPH is characterized by the suitable hemodynamic criteria, the mean pulmonary artery pressure more than 25 millimeter of mercury. As the previous lecturer, the Dae Kim, showed the predisposing conditions, if there is a risk factor and the predisposing conditions for CTEPH, you should find the probability of CTEPH in this patient. And also, patient with acute pulmonary embolism should be followed at 3 to 6 months after the effective treatment. If the patient will have dyspnea or functional impairment, TT should be performed to check the probability of pulmonary hypertension. VQ scan should be performed with a high probability or intermediate probability with elevated NT-proBNP, risk factors for CTEPH, and abnormal CPT result. Let's review a case. The patient is a 70-year-old male with exertional dyspnea for 10 days. He has been medicated for hypertension and diabetes over 10 years, and about 18 months ago, he had pneumonia. And he had a common cold symptom and felt dyspnea about 10 days ago. The NT-proBNP level and the D-dimer level is elevated. Chest X-ray shows the cardiomegaly with the blunting of bilateral CPA, and his ECG shows the RVH pattern. Echo shows the normal LV systolic function, but D-shaped LV, and markedly dilated pulmonary artery, and the mid-systolic notching on the RVOT PW Doppler signal, suggesting the presence of pulmonary hypertension. And there were also RV dilatation and dysfunction and mild TL. His TLV max was 4.5, and the mean pressure gradient is more than 80 millimeter of mercury. And there is the decreased RV systolic function. RV FC is about 34%, and the TEPC was 14. His CT showed enlarged pulmonary artery with mural thrombi, organized wall thrombi, and enlarged RB. And the perfusion defect was multiple perfusion defect. VQ scan, perfusion spect showed a multiple defect. Actually, his CT taken about 18 months ago showed a mural thrombi like this, and is similar to the current CT images. Among several imaging studies in the evaluation of CTEPH, chest X-ray and TT can be used to be in the initial screening, and the CT pulmonary angiography and the VQ scan and pulmonary angiography can be used in the diagnosis and differentiation, and also CT pulmonary angiography and pulmonary angiography can be used the preoperative or procedural planning. In patient with suspected or newly diagnosed PH, or the clinical suspicion for CTEPH, the perfusion defect or chronic thrombi visualization can be done with the VQ scan and CTPA and dual energy CT, LSIM CT, and MRI. Also, selective pulmonary angiography and the CTPA, MRPA can be done in the assessment of vascular lesions in the treatment decision. These imaging studies used to direct visual vascular CTEPH features with the obtuse angles between thrombi and the vessel wall intimal irregularity, and indirect vascular CTEPH features including main pulmonary artery dilatation and the parenchymal CTEPH features with mosaic attenuation, and the cardiac CTPH features with dilated left heart chambers. Because these imaging studies have pros and cons, you should know this. For example, VQ scan is a screening test of choice of CTEPH, but it is specific to pulmonary arterial blood flow. However, but it has perception of being an old, outdated test, and the ventilation may not be available. And although CT, pulmonary angiography, is most widely available test, and show the detailed information about pulmonary circulation, but also long parenchyma and mediastinum, but it has false negative result, require a radiologist with a CTPD awareness and experience, and need contrast and radiation. Let's see individual imaging test with brain storming. Chest X-ray is usually used to exclude other differential diagnosis. As the previous lecture showed, the common finding is enlarged central pulmonary arteries, asymmetrical pulmonary hyperlucencies, and calcified thrombi. Echocardiography is the first line imaging study in the evaluation of PH. It is not a confirmative study of CTEPH. However, it can be used to differentiate CTEPH from CTEPH. A common finding includes the increased pulmonary arterial systolic pressure, enlarged RB and RA size, RB dysfunction, thickened RB walls, and increased pulmonary artery size and thrombus in the pulmonary artery. And the CTPA can be used in the diagnosis and differentiation. CTPA is widely used the tool to search for suggestive finding of pH, confirming diagnosis, if possible, at etiology. DCT can also generate monoenergetic reconstruction, iodine maps, and perfusion maps, enhancing diagnostic accuracy and reader confidence, particularly in case of suboptimal contrast enhancement. These are examples of CT pulmonary artery, including enlarged pulmonary artery and enlarged RB, and the thrombus in the walls, pulmonary artery walls, and the intravascular webs. There are features of CTPA. Also, this is the left main pulmonary artery chronic thrombi with the intima irregularity and obtuse angle, and the PA web and band like this, and dilated right heart chambers with the flattening of interventricular septum, and the calcification in the extensive occluding proximal chronic thrombi with the irregular intimal contour of obtuse angle, and the mosaic schism in the area of hypoattenuation and vascular pruning in the region of vascular obstruction, and this dilated pulmonary artery with the dilated main PA like this. And the CTPA and the DCT can be used to follow-up after the PA. This is the pre-PA, show the occluded pulmonary artery, and the CTPA after PA, patent pulmonary arteries with the PA, after PA. And the dual energy CT, pre-PA show the parenchymal perfusion defect in the area of like this one. And after PA, improve the parenchymal perfusion corresponding with the patent PA. And the VQ scan is the primary imaging study to evaluate the suspected CTEPH. It is especially effective in adequately excluding CTEPH diagnosis as they have a high sensitivity and specificity. Common finding is mismatched perfusion defect. It's large if there is more than 75% of bronchopulmonary segment. This is the feature of the mosaicism area of hypoattenuation of vascular pruning in the region of vascular obstruction and the perfusion defect. VQ scan show the mismatched perfusion defect, red area, with the preserved ventilation. The pulmonary angiography is the gold standard for diagnosing and CTEPH. It confirms diagnosis and additionally helps isolate the specific site of pulmonary vascular involvement and their surgical availability. Biplane acquisition is frequently utilized since it provides more detailed information about the extent and distribution of disease compared to the individual AP or lateral projections. And the common finding includes the remodeling and decanalization process of the clot undergo, Foch defect, intimal irregularity, abrupt vessel narrowing, and the pulmonary artery web and band. This is the example of the pulmonary angiography. It's narrowing of right pulmonary artery, the Foch defect of suboptimal occlusion, and the abrupt narrowing. And this is 2. Let's review a new case with your knowledge, based on your knowledge and my presentation. She is a 19-year-old female with exertional dyspnea. She had been diagnosed and treated with lupus nephritis associated with SLE. She was diagnosed with aortic thrombus by ultrasound examination. Then she had been treated with oral anticoagulation for 2 years. She had faint leg swelling of right leg and diagnosis with deep vein thrombosis in the right leg. And she felt exertional dyspnea and chest discomfort about 1 week ago. Her chest X-ray showed normal size of heart and just little bit engorged pulmonary arteries. And her ECG showed tachycardia with S1, Q3, and T3 with the T-wave inversion in the right read. Her lab showed increased D-dimer and anti-pro-BNP level, and the CT showed enlarged pulmonary artery with the thrombus in the pulmonary arteries, and also enlarged right ventricle. chest echo showed the normal LV systolic function, but there is a D-shaped LV and the enlarged pulmonary artery with the normal the PW Doppler was just a little bit shortened the acceleration time, and there were the dilated RV and the McConnell sign, and the TLV max is about 3.5 meter per second. There's also dilated dilated right ventricle with a dysfunction, but her LV systolic function was normal. And she was treated with warfarin, but she had 2 episodes of admission to the chest discomfort and exertional dyspnea. Although there is a decrease of anti-pro-BNP to about 400, and the D-dimer levels were normal. But she expressed the symptom and the functional impairment. We reassessed the possibility of CTEPH at that time. X-ray shows a similar finding, but there is the T-wave inversion in the sept V1 to V4, and the echo showed the dilated RB and D-shaped LV with the dilated RB and the marked dilated pulmonary artery and the mid-systolic notching of the PW Doppler signal, suggesting the presence of pH, and the RB dysfunction with the RB hypertrophy, and her TLV max of about 4.0 meter per second. Her CT showed a marked dilated pulmonary artery, but there is no visible thrombus. As Professor Kim showed, that we performed the perfusion spect, there is a marked reduced perfusion in the right the pulmonary arteries, and we undergo the pulmonary endarterectomy in this patient, and this is the sample of the extracted thrombus, organized thrombus. After the operation, echo showed decreased size of RB, and there is no D-shaped LV, and the decreased size of pulmonary artery, and her PW Doppler signal changed to normal. Also, there is no dilation of RV and normal RV systolic function. Also, the conclusion: mechanical interventions and/or pulmonary hypertension medication can improve cardiopulmonary hemodynamic, elevate the symptom, and decrease mortality risk in CTEPH patient. Thus, prompt diagnosis is essential. Imaging study is pivotal throughout the management, spanning diagnosis, treatment planning, and assessing treatment outcome. Echocardiography is the first line modality to screen the possibility of CTPD and CTEPH. Pulmonary angiogram, CT pulmonary angiogram, VQ scan, and pulmonary angiography. On experienced multidisciplinary team can determine the treatment modality, including selection of surgical candidates in most cases. Thank you for your attention.